Welcome, everybody. I introduce myself. I'm Solange Madriz, technical lead of education at IGHS. I'm excited to be the moderator for today's talk. We are joining today with three fabulous speakers from the University of California, UCSF. And first, I'm going to start with introductions. I'm going to start introducing the people who are on Zoom. I'll start with Dr. Jyoti Marvin. They have very long, as you can imagine, very long CVs. So I'm going to put some of the highlights of their CVs and their bio sketches. Dr. Jyoti Marvin is a general pediatrician who practices at SF General and is the director of the UC Berkeley UCSF Joint Medical Program. She holds appointments as a clinical professor of pediatrics at UCSF and also as a clinical professor at UC Berkeley. Dr. Marvin is passionate about giving local, regional, and national talks on racism on medicine, social justice, and medical education. She's a member of the UCSF Academy of Medical Educators. Welcome, Dr. Jyoti Marvin, and thank you for being here with us. Next is the person who's smiling, just so you can put a face on what I'm saying. And the next speaker we have today is Dr. Sareen Noor. Dr. Sareen Noor is a pediatrician also at UCSF Benioff Children's Hospital, Oakland, the primary care clinic. She's also the director of the International Clinic within Primary Care, which focuses on the medical care of immigrant and refugee pediatric patients. Dr. Noor has a U.S. civil surgeon designation and provides medical exams for immigration purposes. She is on the steering committee for the new UCSF Health and Human Rights Initiative, and she credits her experience as a refugee from Afghanistan led her to an educational and career path focused on caring for immigrant families. Thank you so much for being here, Dr. Sareen Noor. And last, we have here in person, Dr. Raul Gutierrez. Dr. Raul Gutierrez is an associate clinical professor at UCSF with nearly 15 years of experience working with immigrant children. He is clinically based at Zuckerberg San Francisco General, where he co-founded and co-directs the Bridges Clinic, a multidisciplinary team committed to a holistic and community-supported approach to wellness among recently immigrated children and their families. Dr. Gutierrez is the pediatrics co-lead with the UCSF Health and Human Rights Initiative and the co-director of the Center of Excellence for Immigrant Child Health and Wellbeing with the Benioff Children's Hospitals. Welcome to our speakers, and now I'll turn it to Dr. Gutierrez to give the first talk. Thank you for being here.
Good afternoon, everyone. Thank you so much for having us here today. It's been such a long time since I've done a Grand Rounds in person, so this is really nice. So we are going to be doing a joint presentation. I think we've got like 30 minutes to really pack it in there. We might go a little bit over, so I apologize for that. But we are just going to share this presentation and hopefully take you through a journey of how we're really thinking about immigrant health from a more global perspective. Next slide. So these are our objectives: describe immigrant health with a more global context, understand the operational model of a telehealth clinic dedicated to supporting asylum children, seekers at the border, describe examples of clinical care models for immigrant and newcomer pediatric patients, and list ways to incorporate immigrant health into resident training and other training as well. So I'll do a quick kind of introduction and framing. Dr. Noor will do a little bit more talking on the Center for Clinical Excellence in Training, and then Dr. Marvin will talk a little bit more about clinical innovations, and then I will close it out with some words on partnership and coalition building. So, what is immigrant health? And honestly, it's not really well defined. I think most commonly in the past, we've talked about populations within immigrant health: refugees, migrant farm workers, undocumented populations, international adoption, and all kind of from a different context from those lenses, and more on the adult side versus the children or pediatric side. And for children, most of the research out there is really talking more about second, third generation children and kind of their health outcomes and disparities within those communities. Some of the issues, healthcare and language access, communicable diseases, health disparities, work exposures, and a lot of it from the framework of what is called the immigrant paradox, so this thought that immigrant populations in certain circumstances kind of outperform local populations in terms of health outcomes, wellness, and so forth, despite having worse, maybe socio-psychological or socioeconomic backgrounds. So immigrant health has been kind of spotty, fairly narrow, and honestly, not a huge thing, particularly in pediatrics. Next slide. However, there's been some shifting in our approach to immigrant health, and particularly for the three of us for the past 10 to 15 years. And a lot of that has been because of the changing demographics along our southern border and those people who are coming through. For the most part along our southern border, we're really talking about single adults, mostly men, and historically from Mexico, and that demographic is changing. And as you can see, going back to 2012 to 2014, there was a very dramatic increase, particularly in unaccompanied children, but as well as family units or adults traveling with children, with an overall trend of increasing numbers as well as increasing percentage. And for the first time in 2019, family units and unaccompanied children outnumbered adults, single adults coming from the southern border. Next slide. And for the most part, we're still seeing that trend. So this is more recently numbers. And while single adults do outnumber family units and children at this point, the numbers are very, very high, reaching almost, at least here, as high as almost 2 million people coming through our southern border, with still high numbers of family units and unaccompanied children. 2024 was projected to surpass the numbers for 2023, but with the current executive order by the Biden administration, there might be a lower number than expected at this point. Next slide. And so we kind of needed to take a little bit more of a global perspective. Who's coming through the border? Why are they coming? Why are we seeing more children, and why are we seeing more family units? And when we look at those numbers, we see that about 3.6% of the global population are migrants. Next, you can keep going, Zane. And of those, of that 3.6%, 108.4 million are forcibly displaced by conflict, violence, persecution, human rights violations. Looks like we lost the slides.
I don't think that's, okay, hold on.
We're gonna put it back up.
I don't know if that has.
There we go.
Yeah, sorry.
Or some seriously disturbing public order. And as you can see there, the vast majority of these folks are internally displaced, with a high number of refugees, but also a significant number of asylum seekers or people seeking other international protections. And you can go to the IOM World Migration Report, and it has a really nice interactive website there to look for more of those numbers. Next slide. And children have also been growing in numbers in terms of those who are forcibly displaced, going from about 25 million to 36 million over this 15-year period of time. Next slide. And so these are just some of the major migration and displacement events that we have become more familiar with because of the populations that are coming through the South. And this is not exhaustive, and these are just some general categories: conflict, extreme violence, severe economic and social or political instability, and a growing number of displaced people due to environmental and climate change, which we will continue to see and will probably be the focus of displaced populations in the next 10 to 15 years. And so one of the things that we are starting to think a little bit more is going beyond this narrative of push and pull, and really understanding the complex factors that really inform migration journey, how people arrive to the United States, immigration status, and as well as access to support structures based on that immigration status. And it's really become a lot more complex in terms of how all those systems work and all the different aspects, whether macro, micro, or meso, that inform the way people move across the globe. We've also needed to think a little bit more about trauma, particularly for children. Children face a multitude of traumatic experiences prior to, during, and following migration. And so we really need to understand that context and understand what are the implications and what are the impacts for these children. Next slide. Particularly as we think about ACEs and toxic stress, we start to understand better about neurobiology and epigenetics, generational trauma, and what that means for children, and to actually push back against this idea of the immigration paradox, as we're starting to get more studies and information showing that children who arrive early and as they progress through generations are actually not doing that well. The other thing is detention. Our immigration enforcement systems, particularly detention and processing centers along the border, were never meant to house family and children. And because of this, and because of the policies that go into immigration reform, we have seen a lot of trauma, particularly things like separation from family, sleep deprivation, physical and verbal abuse, medical neglect, and so on and so forth. And so this has really made us think about human rights violations, not only where they're coming from or on their way over here, but also within the immigration detention arena. And just to point out that the US is one of the countries that has not ratified the United Nations Convention on the Rights of the Child, which states that detaining migrant children may constitute cruel, inhumane, or degrading treatment that is prohibited under international law. While we do have other measures to try to help protect children, we've seen that those have been inadequate, and we continue to see harm and even death of children within these situations. Next slide. The other thing that we're really thinking about is immigration as a social and a political driver of health. Most of the things that are impacting families, particularly in the United States, but even along the border and somewhat internationally, is lawmaking. Most of that is anti-immigration laws through restriction, granting minimum rights, or granting more than minimum rights, that then leads to legal practice. And for us, for the most part, that's through law enforcement enacting these things. That changes our environment, changes behavior, and leads to kind of downstream health outcomes in terms of access as well as health outcomes. And as you can see here, I mean, this is just like the surface in terms of the categories of different people that we see in terms of our immigrant population here in the United States. But each one of those things, unauthorized, lawful permanent resident, naturalized citizen, temporary lawful resident, has implications in terms of access to different types of services, not only in the United States as a whole, but within states as well. So somebody living in California is going to have a very different experience than someone living in Texas or Georgia. Next slide. And in fact, over the past 2 administrations or 3 administrations that we've seen, there have been over hundreds of policy changes that have devastated immigration and asylum seekers in terms of their lives here. And that's been through preventing entry, denying status, taking away status, destroying due process, detaining, deporting, or terrorizing, as well as retaliation. And so some of the things through these things that we have really thought about have led us to some principles around immigrant health that we're thinking about. Navigating borders and non-physical borders as well, thinking about clinical innovation, humanitarian versus a law enforcement framework, structural competency, being trauma-informed, practicing cultural humility, celebrating cultural wealth and resilience, and as well as health equity and justice. And if we look at some of the global health principles, and I know these are not exhaustive, I feel like there's quite a bit of overlap here. And so I do not consider myself necessarily a global health practitioner, but based on this kind of local is global doctrine, I might start to think of myself as such. And I do see quite a bit of potential overlap in terms of the disciplines that we're practicing here. Next slide. And so by taking that kind of larger global health perspective, this really opens up immigration health to a lot more things that we can consider and think about, whether that's practicing medicine or public health internationally through local humanitarian aid, or addressing policy that address those kind of push factors, whether that's working at the border at shelters, or writing medical letters for parole for entry, or documenting human rights violations, whether that's this nebulous waiting period before people get some level of immigration status, orientation and access to the medical home, thinking about Medi-Cal expansion or language justice, clinical practice innovation, thinking about immigration relief and using our skills as forensic evaluators to support immigration cases, and then also thinking about ways in which we can be infused into the processes when relief is granted, when there needs to be adjustment of status. For example, you have to be a civil surgeon to do a medical exam to get someone legal permanent residency, or even thinking about citizenship. The government accepts letters of support demonstrating good moral character from people's physicians. So there are many other ways in which we can get involved instead of just kind of this local, narrow idea of what immigrant health is. And so now I'm going to hand it off to Zareen and Jyothi to talk a little bit more about what that looks like.
Thank you, Raul. Hopefully guests can hear us okay. I think that Raul gave a great framework of kind of how we started this work together. So in the context of this anti-immigrant laws that Raul expanded on, and some of the rhetoric that was happening around the Trump election, I think we kind of were like, okay, our institution needs to do something. We need to do something as physicians, as pediatricians, to really help take care of the growing immigrant population in our community, both locally, but also within our state and then nationally as well. So we got together with a group and developed this Center of Excellence for Immigrant Child Health and Wellbeing, where we really wanted to look at how do we create this inclusive community that provides leadership and guidance towards the health and well-being of immigrant children. And we wanted to look at this as how do we provide great clinical services? How do we provide medical care for our immigrant population? How do we train and educate the future pediatricians, as well as our community on different health topics that come up for our immigrant population? And then advocacy is a big one, to really think about the policies and the changes in protocols and policies that affect our immigrant population. So we've got these three pillars that we kind of work on. One is the clinical services. So both Raul and I have these model clinics in our institutions where we provide comprehensive medical care for immigrant refugee patients. And so we have come up with basic screening tools and like ways of approaching a new immigrant patient that comes into our clinic. And then we also think about kind of the overall health of a child, and it's just not the medical care, but it's also a lot of the things that Raul was talking about, a lot of the other social drivers of health, and thinking about getting them enrolled in education, getting them connected to services in the community. And so thinking about how do we partner with our family navigators and our social work department to provide that comprehensive approach to their care. And then understanding kind of the traumas and the stressors that they might experience, either before they left their home country, during their travel, and then here as they're settling into their new community, thinking about that and getting them plugged into mental health and behavioral health services. So having those model clinics has been really, really helpful in kind of developing these standards of how to care for our immigrant population. Our other part is the education. I'll talk a little bit later about our immigrant health curriculum for our residency. And then advocacy is a big one that we do, really, depend on our community partners to, lean on them to help us provide comprehensive care for our immigrant population. So we work closely with our community partners. One of the clinical kind of work that we've been doing is the asylum medicine part of it. A lot of, as Raul was mentioning, a lot of families and children come here seeking asylum, and they have to go through the asylum process, legal process to get granted asylum. And they oftentimes need to present compelling evidence to show that they have a fear of returning back to their home country. And so we provide forensic medical and psychological evaluation to help support those asylees' applications for asylum. And we use the Istanbul Protocol to kind of provide these evaluations. So we collaborate with the UCSF Health and Human Rights Initiative, where we have a medical student-run human rights clinic where we work on providing forensic medical evaluations. We have an adult clinic in San Francisco, and then we've started a pediatric specific clinic here in Oakland, because we know that the evaluations for pediatric population is very different given developmental concerns and other factors that affect children. And so we provide these evaluations that have been very, very successful and helpful for a lot of our families who are seeking asylum. Some of the asylum grant rates. So for people who are seeking asylum, if they're applying without a lawyer support, only about 15% of them get their asylum granted. This increases up to 45% if they have a lawyer representing them. And then nationally, it increases to 85% if they have a lawyer and a forensic medical evaluation that accompanies their application. And then within our institution, in our HHRI asylum rate, we've had 100% of asylum seekers get their asylum granted, which has been really wonderful. So shifting a little bit to our immigrant health curriculum. And so I think what Raul was talking about, how there is an overlap between immigrant health and global health. And we are seeing how we can kind of lean on and learn a lot from our global health curriculum and colleagues on how to train our pediatricians on immigrant health issues. These I'm not going to go into. I think you guys know there's a lot of overlap, and I think Raul mentioned it. So we know that there have been gaps in our training for pediatric workforce. Even our pediatric residents have mentioned that they feel like their education on immigrant health has been kind of disjointed and not very comprehensive. So we work together with our pediatric residents, both from San Francisco and Oakland, to really think about how do we provide a comprehensive immigrant health curriculum for our residents during their training. And so we work together with our residents along with social workers, mental health providers, and interpreters to really think about what are the components to a comprehensive immigrant health curriculum that will prepare residents to care for new immigrant patients when they go out and practice, regardless of what field they go into. We came up with some of these. I'm not going to go into it. If you guys want more information, I'm happy to share these. But just thinking about some objectives of the curriculum, things around clinical competency, understanding really the social and structural drivers of health and how immigration status is not only a social driver of health, but also impacts all the other social drivers of health. Mental health and development, community resources. This is a big one. Really, increasing residents' knowledge of the community resources that are available for immigrant patients. And then advocacy. How do residents and future pediatricians, how do they advocate for their immigrant patients in and out of the clinical settings? these are some of the results of the immigrant health curriculum that we have. We have our asylum, I mentioned our asylum clinic. We have a resident who worked with our interpreter services to come up with some tools for residents on how to effectively use interpreters in a clinical setting. We've had one of our residents get a catch grant through the AAP to work on some curriculum building with Soccer Without Borders, which is a wonderful organization that works with youth, immigrant youth in the Oakland school districts. And we're looking forward to kind of expanding on this resident education. All our residents get our immigrant health curriculum, but we're working on kind of having a little bit more focused time with residents that are really interested in immigrant health to have 2 or 4 week electives. Thinking about getting residents skilled and trained in asylum medicine. So having a longitudinal asylum medicine elective that I think Dr. Trevani is in the audience, who has been working with Raul on building this elective, and then thinking about also experiential electives for residents and trainees. And so one of the things that we've been working on is developing a relationship with our Refugee Health Alliance, which is a organization that is centered in Mexico that has clinics and provides medical care in the different shelters in Tijuana. And so we're working with them to have in-person volunteers where we can go on a Saturday once a month to volunteer on their Saturday clinics and go to the different shelters and provide medical care for the migrants that are kind of at the border. So this is in the works, and we're hopefully going to get this up and running and getting residents and trainees to go down to the border with us to do this work. And I will pass it on to Jyoti to talk about telehealth clinic.
Great. Thank you so much, Zareen and Raul. So I'm going to share just a little bit about one of the innovations that we've been able to do in this clinical space. And specifically, that is that we've been able to run telehealth clinics to support families at the border. Next slide. And so in terms of how we got here, I think it's important to note that this effort actually came out of a youth advocacy effort. So young people in the Bay Area who were really appalled at what was happening around the rhetoric of the Trump administration and just the state of children in detention. And they decided they wanted to do something about it. And so the youth themselves decided to start an advocacy project around making butterflies to help to bring awareness to what was happening to children at the border. I've got butterflies behind me that are part of this project. And as part of that, a few of us went down to the border to do some humanitarian aid. While we were there, we met up with a group called the Sidewalk School, and the Sidewalk School has now become our partner in running telehealth clinics. You can read the slide yourself. So the sort of shorter story here is while we were down volunteering in Reynosa and in Matamoros in Mexico, which are just across the border from Brownsville, Texas and McAllen, Texas, we worked with folks at the Sidewalk School who shared that there was a real need for medical care and specifically pediatric care for children asylum seekers. As you know, children and their families are sort of amassed at the border waiting for the opportunity to come over to seek asylum. And so obviously there are a lot of children with medical problems there. And so the Sidewalk School, which does case management basically and humanitarian support for families at the border, shared with us this need for medical care. And so as many of you are familiar with, sort of what you do in that situation is sort of figure out what's happening on the ground and how can we effectively collaborate with the providers on the ground. So we formed relationships with the Sidewalk School, with MSF, and with a group called Global Response Medicine. And then in consultation with all of those groups, we did decide at their request to start some telehealth clinics. And so that started in February of 2022. We are currently doing telehealth clinics. We're also providing letters documenting medical urgency in patients, and then doing medical documentation review. And I'll talk more about those on the next slides. Very briefly, just to give you a sense of the scope of the telehealth clinics, when we were kind of at max capacity, we run about 4 telehealth clinics a week. 2 in Matamoros, 2 in Reynosa. We run these clinics in conjunction with the Sidewalk School. So the Sidewalk School hires nurses who go out into the community, into the shelters, into the encampments. They find people who have medically urgent cases. We have volunteer physicians who just hop on to WhatsApp video once a week and spend a couple of hours seeing patients who the nurses bring into the clinic space, which is either at a local shelter in Reynosa or at the Sidewalk School's office in Matamoros. We are able to purchase medications and order labs thanks to some small grants that we have. And we work very closely with clinical partners on the ground, including Refugee Health Alliance, MSF, and a group called Med Global. I've also been down to the border a number of times to do in-person meetings, just to build relationships with folks at all of those organizations and to get a better sense of what the actual on-the-ground needs are. Next slide. I think I've gone over most of this already. The thing to note on here is that we do depend heavily on our medical partners on the ground. And so we often will refer patients to be seen at the in-person clinics run by MSF or Refugee Health Alliance or Med Global. The challenge, as you already probably know, is that all of these on-the-ground groups are really so stretched in terms of resources. So anything that we can take off the top and any reassurance or advice that we can give ends up being very helpful and valuable just because it allows those groups on the ground to see more patients. Next slide. You can see our numbers here. When we first started March 2022 to February 2023, we did about 65 clinics. We had a real explosion in clinics over the following year, 23 to 24, partially because we had more volunteers, but also obviously the number of people at the border were increasing. We also were able to recruit some more adult providers. So we were able to do not only pediatrics clinics, but adult clinics as well. And then since March of 2024, you see our current numbers here. We've done fewer clinics, and I'll talk more about that in the next couple of slides. But it has a lot to do with one of the big challenges for us has been just the constantly changing politics at the border and how that's impacting the number of asylum seekers and where people are going. And so we've had fewer clinics over the past few months, which I'll talk more about on the next slide. So two of the other ways that we've been helping, in addition to the actual telehealth clinics, is just by by writing emergency medical letters. So we do this in partnership with the Center for Excellence for Immigrant Child Health with Zareen and Raul. And you can imagine that some of the children who are arriving at the border have really urgent medical needs and can't sort of languish in shelters or in encampments for months and months as they're waiting for these very precious CBP-1 appointments which you get by using the CBP-1 app, which is often glitchy and not that easy to use. So we have written letters of medical urgency saying that children with some of these needs and many, many other needs have a more urgent need, can't wait for a CBP-1 appointment, need to be able to cross to plead their asylum case sooner and be able to seek medical care while they're in the US. There's an asterisk with this and with the next slide because given the June 4th new executive order, a lot of this is very much up in the air at the current moment. We're still trying to figure out how effective are these letters right now, if they're being accepted. I think the official word is that they're supposed to be accepted, but the experience of our partners on the ground is that they're not being accepted right now. So this has been one of the things that's up in the air, along with, on the next slide, our medical documentation review. So our partners at the Sidewalk School get, thousands of pages of documents from asylum seekers. And since they're not clinicians, they don't know who is urgent, who's not urgent, who might need to seek medical care. And because the Sidewalk School serves as a first stop for many people and can help people with a little bit of wayfinding, they will send us some of their medical documentation just to say, what does this person need? Is this an urgent case? Is this someone that we should be sending for a medical urgency letter, or is this someone who should be going to one of the local clinics here to get additional care? So we have volunteer MDs who just review the medical documentation, help to provide advice on what the next step for that asylum seeker should be. And often it is referring to the hospitals or Refugee Health Alliance or Med Global or MSF for more immediate escalation of care. Next slide. We've also been able to involve trainees in our clinic at lots and lots of different roles. The data that you saw was pulled together by a resident and a volunteer. we've had residents sitting in, medical students and residents sitting in on clinics, helping with just doing in the moment research, sometimes helping with interpretation, and helping us to develop clinical resources. And without exception, everyone who's been able to do that experience has said that it's been a very valuable experience. And has also helped them understand and be more empathetic to patients that they're seeing clinically at San Francisco General Hospital and at Children's Oakland. Next slide. Great. So I'm going to hand it back over to Raul to close us out by talking about some of our partnerships and how we can move forward.
All right, so I'm just going to close this out and then open us up to some questions. So looking back at our next slide. Looking back at our just kind of list of ways that we can get involved, right? We've been trying to fill in like who's doing this work, not only here at UCSF, but how can we do it? How can we build a better coalition of everybody who's doing this work? So we talked about our partners with Refugee Health Alliance. We talked about the Sidewalk School. I have the Bridges Clinic over at the General. Zareen leads the international clinic over at CHO. There's a newcomer health clinic with family medicine, Clínica Martín Baró, which is a free clinic through the Latinx Center of Excellence. And there are other departments doing very similar work around just kind of this waiting period and clinical innovation and things like that. In terms of immigration relief, Health and Human Rights Initiative, of course, and the HEAL Fellows in terms of broadening the scope and the reach of people who want to do this type of forensic evaluation, as well as partnering with Trauma Recovery Center, who does similar work on the psychological side, and also kind of thinking about innovative partnerships. We have ImHelp, which is a collection of both mental health providers, medical providers, and lawyers, and we're really thinking about innovative ways to be able to provide things like universal affidavits or medical expertise background to explain to judges why is it that a person is not seeming all that traumatized when they're being questioned by the attorney? Why is it that they, is what they're saying an exaggeration? Why can't they remember certain things, right? And this is just like, immigration judges just don't know this, right? You can imagine an immigration judge trying to talk to, a 12-year-old about their experience, right? Or anybody, or even an adult who had trauma as a child and is dissociating or is using other types of coping mechanisms that don't present the way one would think they would present. We're also thinking about coalitions in our communities, right? So connections to networks such as the SF Coalition of Asylee, Immigrant, and Refugee Services, which there are several in different counties. Each county has one. And then just thinking about expansion of civil surgeons. Most civil surgeons actually charge for services for that medical exam, the x-rays, the immunizations and lab tests, and that can sometimes be thousands of dollars. And the thing that is holding someone up from getting legal permanent residence and all the benefits that you get from that. So how can we expand that and provide that in a pro bono type of way with a humanitarian kind of framework? Next slide. Synergies with local initiatives. These are just some broad categories: refugee resettlement partnerships, cultural community engagement, interpreter services, research collaboration, local advocacy groups, including our legal friends as well. But these are just general things that we think about in terms of expanding how we're doing this work and how to incorporate other people from other fields who are also passionate about the care of immigrant communities. Next slide. And this might look like something more nationally even. So both Zareen and I are part of SCAN, Specialty Care Access Network for Children. We know that even when people get here in the United States, they are still migrating. People who arrive in San Francisco are just kind of like, it's too expensive here. I have to go somewhere else. People who end up in North Carolina are like, my kid can't get the care that he needs. We need to go somewhere where he can get the care. And so we have this network of champions across the United States to help us navigate getting kids plugged into specialty care when they arrive in different states, because each state is going to have a different approach and different things available to them to get that care. And what does this look like nationally? we've been kind of leaning on this idea of transnational solidarity, where clinicians work with migrant populations to challenge the stigmatizing narrative around migrants, provide in-person or telehealth care to migrants with limited access to services, channel critical resources across and along borders, and challenge immigration policy that incurs harm and undermines clinical neutrality. Next. And so really we need to think about collective action or any form of organized action, whether social or political, carried out by a group who want to address a problem to or achieve a goal. And that I think is really important as we talk about advocacy, because as we've kind of established, policy and upstream policy is really that's causing all the downstream harm. Next slide. And so if you think about the policy spectrum here as it relates to advocacy, we really want to get to the influence-based advocacy, systems advocacy, and policy advocacy. And for that, we really need all the players to be able to help us think about these bigger upstream changes that need to be made in order to benefit these communities. Next slide. And so our ultimate goal is really to improve the lives of children in our community and around the world through comprehensive, collaborative, and culturally sensitive approaches to address the health challenges in an increasingly interconnected world. Next slide. And so I'm going to leave you all to read this poem if you'd like, Things We Carry on the Sea by Wang Ping from 1957, and we will open up to questions.
Thank you so much to Dr. Rodriguez, Noor, and Marvin for this wonderful presentation. And I have to say, it was very moving. I'm an immigrant myself. And just to make it clear, you are a global health practitioner. You are one of us and consider the faculty affiliate program to make it official. But you're definitely a global health practitioner. There are several questions from the audience and from us. I'll just get us started with some of the questions. And for the audience, prepare your questions. We have limited time, so I'm going to open it for the group shortly. But my first question comes for Dr. Noor. It was very striking to me to see the success of your center in providing 100% of the cases you're granting asylum for those children or individuals. I wanted to ask you, what do you think are how do you make it happen? Because it sounds like it's very, very complicated. Me as myself in a very different category, but with a lot of obstacles on the way, but you're still making it happen for many individuals. So if you can talk about it, and also if you can give us a number to have a sense of how many people you've been able to help.
Sure, wonderful. Yeah, so for those who are not familiar with the forensic evaluation, it's it's a long, it's not a medical visit. It's not, you're not trying to diagnose something and provide medical care for somebody. It's really sitting with the family and understanding the traumas that led them to leave their home country, and so that requires time and a lot of skill to help open them up and talk about these very traumatic things that have happened to them. And we get that information and we write an affidavit, we write a report that says like this person had experienced these traumas, and these are some of the signs and symptoms of those trauma, and they are they are consistent with the trauma that they're explaining. So we oftentimes do like both a psychological evaluation, but sometimes physical. Some of our clients that come in have physical findings of abuse that they've experienced or trauma that they've experienced, and we evaluate those and write this into a report. And so the judges who get these reports, I think part of it is us being UCSF, right? This institution, this higher education institution, and they trust that what we write in this report is true, and they use that to help kind of decide whether this case, this person has truly experienced this trauma. And so So we've been able to do this. I right now cannot think of the top of my head how many, but we have a asylum clinic once a month, and for the pediatric ones, and we see anywhere from 2 to 3, 4 clients at a time. Raul, do you know our numbers?
I don't know if it's or not, but I think it's okay. I want to highlight, of course, Dr. Trevany DeFries, who's over in the back there. Who's the director of the Health and Human Rights Initiative. And I think with her leadership, along with everyone else who's part of it, I mean, this is really a multidisciplinary approach across the Bay, with folks from psychiatry, pediatrics, internal medicine, family medicine, emergency medicine. Sometimes we even get like neurology and dermatology and other folks to really help us out with this. And then we have all these great minds who are really passionate about this and really thinking in a trauma-informed way, and really helping each other build our skills to be able to do this. But you know, I want to highlight Trevany's leadership on this, and Trevany, I don't know if you want to say more about the success.
We've done almost 300 evaluations. It doesn't sound like that many when we think about it compared to like the amount of clinical visits we do in a hospital or clinic, but these are really in-depth. They take a lot of time and a lot of collaboration with the trainees. So that number is fairly high volume actually in terms of like the field. And I think there's a couple of things that get us to that grant rate of 100%. One is there's huge backlogs in the immigration courts, and so many of our clients haven't gone to court, or their date has been bumped over and over and over. And so 100% is for the patients, the clients who have gone to court. We don't know what's going to happen with everybody yet. We're still waiting. We also, this is highly dependent on jurisdiction, where in the country you actually have your case heard. And it's very geographically dependent. It's not hugely surprising that here in San Francisco County, which has the most asylum claims in the country, we have a fairly good grant rate. We have judges that are very different than a judge you might find in Georgia or a different state. So that also contributes to our grant rate. But I do think we're really trying to set the bar in terms of high quality in this field. This is a new field clinical area of asylum medicine, and so we're really trying to be engaged also nationally and saying, hey, these are our best practices because they really seem to work, and we're trying to also establish that.
Yeah, and I want to say that HHRI really believed in us as pediatricians doing this work. We're one of only 2 clinics across the country who focus specifically on pediatric patients.
Thank you. And I want to ask you, Dr. Trevany, since you're here also in the room, and for the ones who are on Zoom, they are here. As one of the questions that I asked at the beginning was, who from the room are interested in this topic? And I wanted to ask you, I'm sure that even right now, I know that there are people that will be interested in collaborating or even volunteering and working with you to support these efforts. And I wanted to ask on behalf of them, what would be the best way to reach out? Is it an email, or what would be the best one? And now, honestly, just tell us so we don't waste your time if you're open for that.
We are open. We are so recruiting UCSF faculty who are clinicians to become volunteers in our clinics. We have gotten almost 2,000 referrals for cases. We have so many more referrals than we can possibly take. So if there's any clinicians in any specialty that want to be trained and work with us, please come work with us.
And what about besides clinicians? Are there any other skills that are desirable?
I think reach out. I think that we should find a lot of different ways for people to get involved. We're sitting on a huge amount of high quality data. We have this electronic data capture system. I think we're the only people in the country who have that in a program like this. And we really need collaborations with researchers and people who have skills to analyze some of our data. So we would really welcome that as well. And I'll also pass it to Jyoti, because I believe that there's also a need for volunteers on her end.
Yes, absolutely. Thanks so much, Trevany. It's a little difficult to hear on Zoom, but it sounds like for volunteers, we definitely would also love if there are volunteer clinicians who are interested in doing some of the telehealth clinics. We'd love that. And then I'd echo what I think I heard Trevany say, which is, and others with other skills, we often need just help organizing or keeping track of spreadsheets or data analysis. There's so much to do. So definitely feel free to email me if folks are interested in the telehealth clinic support specifically.
And the other thing that I would add is that I am trying to get us to have a university-wide agreement with Refugee Health Alliance to really expand those experiences at the border in Tijuana. And so I'm hoping that will have a lot of potential, not only for educational exchange, but potentially even for capacity building, program evaluation, or just going and hanging out with us and doing some of that volunteer work. They do also accept 2 to 4 week away rotations and things like that too. So if that seems interesting to you as well, please reach out to us.
Thank you. Thank you so much. And now I would like to ask the audience if there are any particular questions that you would like to ask our colleagues that are joining us today on this topic. But please, Muna. Muna is one of our PhD students who are interested in this topic. Muna, welcome.
First off, thank you so much to the speakers for doing this important work and sharing this information with us. Considering that one of the best gifts we can give a child is a safe entry into the world, has there been any effort made to expand these currently available services to pregnant and new mothers in the detention centers?
That's a really great question. At the moment, all the family detention centers that used to be running aren't running at the moment. So that's a huge win. I think pregnant people at the border have been one of that subpopulation where they do get entry into the United States without as many barriers. That being said, it is one population that I don't think is getting as much attention in terms of the support systems around them. As you can imagine, depending on what state you go to, your access to prenatal care is going to be different. Some states have Medicaid programs for people who are pregnant, some others don't. And so depending on what state you are, the type of prenatal care that you're going to get, and of course the outcomes and the disparities that we see there are going to change differently. We do know from our colleagues over at the Stanford Immigration Lab, which is a bunch of sociologists who do amazing work, that when states do enact waiver programs for Medicaid to expand prenatal care, outcomes improve dramatically. Here at our institution, there have been a couple of champions in OB who have really been thinking about also clinical innovation and how to capture these families as best we can. At the moment in Bridges Clinic, we do see kids who are born here in the United States to pregnant folks who just arrived. So even though the child is an American citizen, we still provide the same type of wraparound approach to that family because of the proximity to the parents' recent immigration.
I can just add, very briefly, I can just add to that as well. In terms of the letters, when we're writing letters, if any person over 37 weeks pregnancy, we write a letter and they cross with very little issue. So that I think is not a whole-scale solution, but is definitely helpful. And Refugee Health Alliance is doing some really fantastic work with doulas and prenatal care as well. So again, another plug for the great work that they're doing in Tijuana and Reynosa.
Thank you, Jyoti. And we have one more question. This will be the last question, given that of the time. So, but go ahead, Dr. Chris.
Not a question, just a comment. I wanted to thank Raul, Zareen, and Jyoti for dedicating your career to advocating for children. And I had the honor of training with both Raul and Jyoti, and it was so inspiring and just to see them after a long shift in the PICU, that they would leave to advocate, march in San Francisco or go to Capitol Hill to advocate for children. So just wanted to thank you for your dedication and your service.
Thank you so much. Thank you. Oh, one more question? Okay, one more question. One more question.
I did the same thing, trained with Raul and it's just so exciting to see like the outcomes of the program and
this amazing work you all are doing. But just two questions. What are the legalities of practicing telehealth if you have a California license? And then, and you're practicing in another place? And then who pays for all this? Like, how are you all funded for the whole program and the medical care for the the patients or the clients?
I'll let Jyoti start.
Yeah, great. I joke, not joking, that our telehealth clinic is a little bit like duct tape and bubble gum held together. We are really fortunate in a great example of what an institution can do and the power of an institution. UCSF is actually covering malpractice for the physicians who are UCSF faculty volunteering in the telehealth clinic. It's part of the global disaster, the GDAC, global disaster, something. But basically recognizing that the border is a disaster area in terms of the impact, the health impact on people there. So we're really very grateful to UCSF as an institution and risk management for getting behind us on that. In terms of funding for the telehealth clinic, it's all individual donations that is funding our program. And Raul and Zareen can talk more about funding.
Yeah, I can. Oh, go ahead. Oh, yeah. So just a few funding, so for the civil surgeon that Raul was mentioning that I do, I think is possible for clinicians who are out there. I see my patients in clinic. So if there are patients that come to our clinic, I will do those evaluations, and I have a relationship with the Oakland Unified School District to get students who need those evaluations into our clinic, and we have some school-based sites, and I do a well child visit, and I do the labs, and I do the forms on my own time. So it is definitely doable in providing that care within a clinical thing. Our asylum clinic, we have some funding from the county, from Alameda County, to do some of this work, as well as some donor foundations who have support our work to do that work. But it's all pro bono, like the providers who do those evaluations do it on their free time. And we have medical students. Another shout out to this wonderful team that Trevani helps support, is our medical students who do a lot of the care coordination and the coordination with the lawyers to get our clinic up and running. So that's all done. And we have some administrative support that we pay through our grants. And then what else are we? And then our individual clinics, Bridges Clinic and our international clinics are within our institutional homes, or I get our primary care. We're FQHC with a federally qualified health center, and within that, I've carved out these clinics. And then Raul can speak to kind of Bridges Clinic and how that's funded.
Okay, yeah.
Very short.
Yeah, just very, very short. So as you can see, humanitarian work is not something that is like super well funded. So it's a portfolio of different things: volunteer work, in-kind stuff from your institution, some monies actually from the institution, grants, philanthropy, and it's just a whole collection of those things. But we can do some work on strengthening our humanitarian funding.
Well, thank you so much once again to our speakers. Really, the dedication, the passion, and that you have for immigrant health really came across. And me, as myself, as an immigrant, I have to say thank you for being a voice for those who don't. So thank you so much, Dr. Marvin, Dr. Noor, and Dr. Gutierrez. Thank you so much. Gracias, and see you next time.